Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. Today in our class, we are going to talk about the metabolic alkalosis and its clinical features. Metabolic alkalosis, as I told you already earlier, is a condition associated with the elevated pH more than 7.45 with the elevated bicarbonate concentration. The various factors responsible for the metabolic alkalosis were covered in the previous class. And now I'm going to touch on the metabolic alkalosis and its clinical presentation. The clinical presentation of metabolic alkalosis could be due to alkalemia, that is hypoventilation leading to sometimes complicating hypoxemia, because metabolic alkalosis is compensated by the lungs by hypoventilation, which we talked earlier, but it is limited by hypoxemia. And the features related to etiological causes and the features related to electrolyte disturbances, which will complicate the features of the etiological cause. So coming to the metabolic disturbances that lead to the manifestations of metabolic alkalosis. They are hypokalemia and hypocalcemia. Okay. The mechanism of hypokalemia has already been discussed in the pathogenesis of renal response to metabolic alkalosis. Well, hypokalemia results in weakness of the muscles and cardiac arrhythmias, polyuria due to impaired urinary concentration. Okay. Hypocalcemia. This may result in muscle cramps, which are painful, carpopedial spasm, again painful spasm of the muscles, sometimes convulsions. So hypokalemia will manifest as the muscular weakness, cardiac arrhythmias leading to congestive heart failure, polyuria due to impaired urinary concentration. Muscle cramps, cardiopedial spasm, and convulsions could be the manifestations of hypocalcemia. Because in alkalosis, there is a decrease in the concentration of ionic calcium, because calcium gets deposited as the calcium phosphates, and the ionic concentration of the serum calcium will be diminished in alkalosis. Cardiovascular disturbances secondary to alkalosis. It may result in hypotension because of secondary to hypovolemia. Hypovolemic reduced cardiac output could result in the hypovolemic shock. And supraventricular and ventricular arrhythmias could be the result of hypokalemia. Neurological manifestations and the features of muscular system. Alkalosis results in increased acetylcholine. Okay. And reduced calcium leading to muscular cramps and the convulsions. There is increased neuronal excitability secondary to hypocalcemia. That results in the manifestations of paresthesias, muscle cramps, sometimes tetany. Other CNS manifestations include nausea, disorientation, stupor, sometimes leading to coma. Okay. As such, alkalosis results in the reduced cerebral perfusion, resulting in the CNS manifestations. Coming to diagnostic evaluation. Detailed history is very important with regard to history of persistent vomitings, history of gastric aspirations, and history of bicarbonate administration, and history of recurrent blood transfusions. Okay, I will give you an idea related to the excessive loss of hydrogen or excessive administration of bicarbonate, which may perpetuate the occurrence of metabolic alkalosis. Then coming to physical examination, there will be signs of volume depletion. Look for the signs of volume depletion in the form of hypotension. Patient may be disoriented, and there could be impending shock. You all can also look for the signs of hypervolemia. Okay. And ask for a blood gas analysis in order to understand the pH and level of bicarbonate in the serum and partial pressures of carbon dioxide, and also will give you an idea about the calcium levels. Okay. And look for the serum electrolytes with regard to the serum sodium, potassium, to know the presence of hypokalemia, and serum calcium and phosphorus to look for the hypocalcemia, and urinary chloride. There are situations wherein urinary sodium will be low in case of hypovolemia, and sometimes in conditions like the chloride resistant metabolic alkalosis, there will be increased expression of sodium in the urine. Well, metabolic alkalosis with hypovolemia. It could be renal or extrarenal in etiology. Okay. Hypovolemia leads to reduced filtration of bicarbonate. It results in hypokalemia with increased absorption of bicarbonate. There is depletion of chloride, and there is urinary chloride will be less than 50 millicalors per liter, and it will respond to sodium chloride infusion. This is usually associated with fluid loss due to persistent vomitings or chloride losing diarrheas. Then renal causes of hypovolemic alkalosis. The main cause is diuretics. Loop diuretics or thiazide. It again results in metabolic alkalosis associated with hypovolemia. There could be secondary hypokalemia, hypovolemia, and hyperaldosteronism. It is estimated 3 to 50% of diuretics users, they suffer from this condition. Well, thiazides increase bicarbonate by 2 to 7 milliequivalents per liter, and loop diuretics increase up to 15 to 20 milliequivalents of bicarbonate in the serum. In these conditions, urine chloride drops to less than 15 milliequivalents per liter. Coming to Bartter syndrome. Bartter syndrome is a rare syndrome associated with metabolic alkalosis, hypokalemia, hypochloremia, and hyperuricemia. There is increased angiotensin mechanism with normal blood pressure. It associates with the elevated urinary chloride levels, and you will find the hypertrophy of the juxtaglomerular apparatus. Gentleman syndrome. This is again a rare condition associated with metabolic alkalosis and hypokalemia. There is hypomagnesemia and hypocalcemia. It is associated with decreased urinary chloride. And the main defect is in this condition is the distal tubular defect with sodium chloride. It leads to hypovolemia and stimulation of renin-angiotensin-aldosterone mechanism, presents with the muscle weakness, cramps, tetany, and seizures. Hypotension, dizziness, and prolonged QT interval are the other phases. This is a rare syndrome. So far we have dealt with the renal causes of hypovolemic alkalosis. Coming to the extrarenal causes, they include upper GI causes and others. The upper GI causes includes persistent vomitings, NG aspiration, which leads to loss of hydrogenase and excessive bicarbonate retention. Volume depletion results in hyperaldosteronism, complicates hypokalemia and hypocalcemia. And other causes being laxative abuse, cystic fibrosis, chloroduria, yes, chloride deficient formula, which is given to the infant feeding. So these causes have already been touched in the previous classes. Only to repeat, the external causes of or GI vomiting, GI causes being persistent vomiting, NG aspirations, which leads to loss of hydrogen and retention of bicarbonate. And excessive laxative use, cystic fibrosis, chloroduria, chloride deficit formulas when fed to the infant. All these things are going to lead to hypovolemic alkalosis. There is another situation wherein there is hypervolemia with metabolic alkalosis. This is associated with the elevated urinary sodium chloride, which is more than 20 milliequivalents per liter. This condition is resistant to chloride infusion. It is further divided into associated with hypertension and that without hypertension. Conditions associated with hypertension. It could be due to primary hyperaldosteronism. There is retention of sodium and chloride. There is hypervolemia and hypertension. Cushing syndrome because of hypercorticolism. Renovascular, which is associated with renal artery stenosis, and Liddell syndrome. The conditions associated without hypertension, okay? In this, there is no elevation of renin, no elevation of mineralocorticosteroids, but there is excessive intake of alkali. And the history of repeated blood transfusions, which results in excessive alkali, because citrate is used as an anticoagulant in the blood, and repeated blood transfusions are going to result in alkalosis, and that results in the alkalosis with hypervolemia and hypertension. Coming to a brief note on the treatment. The first line of treatment is the treatment of the cause. Okay, treat the cause, either it is the renal cause or due to the administration of diuretics, or it could be the GI cause associated with the persistent vomitings or the NG aspirations. So instead of the recurrent gastric aspirations, use the proton pump inhibitors to in order to treat the associated gastritis and treat the persistent vomitings, and go with the fluid therapy with normal saline. Give potassium supplementation. Administer acetazolamide in order to, it is the carbon kinase inhibitor. So it is going to help assist you in the management of metabolic alkalosis. Infusion of HCl or ammonium chloride or arginine chloride is going to correct the alkalosis associated with hypochloremia. And in resistant cases, proceed with dialysis. Well, prognosis depends upon the cause. So thank you very much for patient listening. This is all about the metabolic alkalosis and its factors responsible for the initiation of the metabolic alkalosis and the factors that complicate and maintain the metabolic alkalosis. And the clinical manifestations extend from the related to the hypovolemia and related to the electrolyte disturbances. Okay. And early identification is very important in order to reduce the morbidity and mortality. Thank you very much for the patient listening. I'll meet you again in the next class. Until that time, bye-bye. Thank you once again.